speaker of the session and an amazing woman who is presently the Honorary Secretary of GSI is Dr. Chandrima Paul, who's going to concentrate on surgical treatment, teaching of trabeculectomy. On to you, Dr. Chandrima.
Thank you very much, Dr. Chitra and AIOS for this invite. It is indeed a pleasure to be here on board with stalwarts. So I'll go right away to my presentation.
Thank you so much.
Could others be on mute, please? Could others be on mute? Yes, Dr. Chandrima.
Preventing complications and taking you through it. So glaucoma surgery has traditionally been all about efficacy, and serious safety issues have promoted evolutionary improvements. So surgical therapy for glaucoma is usually resorted to in case of failure of conservative treatments. Trabeculectomy was described as early as 1968. To date, the gold standard for glaucoma surgery is trabeculectomy. Wound healing at the conjunctival and episcleral plane, that's the limiting factor for the success of trabeculectomy. Antifibrotics like 5-fluorouracil and mitomycin C have been widely used for wound modulation to improve the surgical success. But however, they have been a little costly to us in terms of post-operative complications. So as they say, old is gold, old wine is the best to taste, old horse to ride, and old friends to trust. So also trabeculectomy, as I told you, is the most popular form of glaucoma filtration surgery and remains the gold standard for surgical reduction of the intraocular pressure. So the advantage of trabeculectomy over prior full thickness filtration procedure was the concept of guarded scleral flap, which reduced the rate of complications related to overfiltration. And in 1980, modifications to increase the efficacy and reduce complications like suture lysis, modifications of flap, superior wound closure, use of antifibrotic agents, as I told you, have contributed greatly to the success of trabeculectomy. The decision to operate depends on the patient who is unable to use the medicine, ocular intolerance to the drops, unable to reach the target intraocular pressure, and when there is documented progression. For surgery, the advantages are potentially unlimited reduction of intraocular pressure, long-term cost of laser, etc. is saved, little or no impact on quality of life. Well, that is a little bit with a question mark, and independence of patient compliance. The disadvantages of surgery, however, are the complications, both intra and post-operative and late post-operative, loss of control of IOP over time, about 10% reduction every year, and the need for additional medications if and when they are required. So the modifications in technique have come with the scleral, with the square flap, the triangular flap, the semicircular flap, the trapezoid flap, and a lot of these have changed over the years, the fornix-based, the limbus-based, the releasable sutures, but in the long run, I feel it's that which works best in your hands that you should stick to. Wound healing, most common cause of failure is scarring in filtering bleb. So we use antifibrotic agents, like I told you. But here we must remember one thing, that trabeculectomy is a surgery against nature. In all other surgeries, we actually pray for healing, but here we pray for not healing. So that's the difference with trabeculectomy, and using the antifibrotic agents in these are the cases where we use it in lower age groups, aphakic or pseudophakic eyes, neovascular glaucoma. And with that, I move on to trabeculectomy is an excellent procedure when it succeeds, and to ensure that it does, you've got to avoid many landmines along the way. That's conjunctival buttonholes, over and under filtration, and hemorrhage. And over the years, we've seen that surgeons do well and could do better when performing this procedure, and in came the Moorfield safe surgery system of trabeculectomy. So I have no financial interest out here, but if you instill a drop of brimonidine into your conjunctival sac just before you start operating, it could help you see your way through the bleeding blood vessels. Next, we move on to the operating steps. So I'll start with the Vexel fluid dissection. Here, actually, you have to be sure that you have a non-tooth forceps, and that's where you just slightly move your bud over the conjunctiva to release it so that you have a freely moving conjunctiva. And this is the incision that I generally use. I do a fornix-based trabeculectomy, but that's not what you should practice if you are not comfortable. You should go with the surgery that you are comfortable with. And this is something I have designed for using the mitomycin. We put the conjunctiva on stretch, so a wide pocket for applying the antimetabolite sponge underneath the conjunctiva. I generally use a concentration of either 0.2 or 0.4 mg per ml for 2 minutes. And that's a no-touch technique for putting in the mitomycin. And then, of course, all of us, as you know, we wash the area with Ringer's lactate once you've distilled water, once you've finished with your mitomycin. Next comes one of the most important steps, that is the scleral flap or horizontal incision parallel to the limbus. Dissecting a partial thickness scleral pocket is made. The two sides of the incision are cut with specially designed scissors. I call them the scleral scissors. I designed the scissors as well. And they actually reach just up to, just falling short of the limbus. So we have a wider surface area for the movement of the equus. And next we have the punching of the ostium. So that's a non-shelved incision at the sclerolimbal junction, and I generally punch it out with the Kelly's punch, or I sometimes also just use the venous scissor. And iridectomy. Iridectomy is has to be done and well, and not partial, but complete iridectomy. So that generally done with the scissors parallel to the iris plane. And it's advisable to use releasable sutures. So that's a releasable suture that you see there. So it's relatively simple. Just take it in through the limbus, in through the conjunctiva, and through the scleral flap onto the inner lip. And after 4 throws, just take out that loop, and that's your releasable suture. And it helps you titrate the IOP post-operatively. And the conjunctival closure is done with a round-bodied needle, not a cutting needle. Make sure that you don't injure the conjunctiva when you are sewing it up. So with that, you will finish off with trabeculectomy. Just a small clip on phacotrabeculectomy, because that's what we do more often nowadays. So I always prefer a double site phacotrabeculectomy, but I sit at the superior end, but I do not shift my position. After making the flap, all I do is just extend my hand a little bit and do the rhexis and the phacoemulsification. As you see out there, the flap is done superiorly, and then that's where I enter. And I finish my rhexis from the side of the flap and the hydro, and then the phaco probe through that incision as well. And this is ologen. This is a relatively older surgery of mine when I did triangular flaps. So it's important to do a releasable suture when you're using ologen, so that helps you titrate the intraocular pressure post-operatively. And it's relatively simple. Just after completing your trabeculectomy, that's the ologen. Ologen comes in 2 sizes, 6 millimeter diameter or 12 millimeter diameter. So that's a 6 millimeter diameter one. And you just place it over your scleral flap and you close your conjunctiva. So trabeculectomy provides a non-physiologic route for aqueous outflow, and complications may occur despite the best efforts of the surgeon. Timely detection and management of these complications is vital for a good surgical outcome. So these complications can be divided into peroperative and post-operative. So here I'll show you one of the dreaded complications. That's the torn flap, which happened. Just look at that. I punch out the ostium and see what happens. I've pulled out the flap. But not to panic, complete your surgery. That's the iridectomy done, and then suture the flap back. And that's how you place it right where it should be, and suture the flap back so that it creates the normal scleral flap that we want in trabeculectomy. And once you've done that, it's fine, and there is no need to panic. But then when it does happen, you do get panicky. So that is it. Actually, the flap is sutured back, and it's almost as good as normal scleral flap. And this is one of the dreaded complications that can happen. It happened to me while doing a live surgery. So look at that. This was a myopic eye, and I didn't see the patient before surgery because it was at a workshop. And look what I do. The sclera was relatively thin, and there it goes. So again, not to panic. So all you have to do is basically close up that wound completely and start afresh. So I closed that and then I started afresh. And I was actually doing a shunt in this surgery. And I did my surgery just as it was planned. And that is it, basically. So peroperative surgical pearls are considered topical or bulbar anesthesia. Never use tooth forceps to handle the conjunctiva. Aim for watertight conjunctival closure. Lower high preoperative IOP. I always use mannitol 100 ml before surgery and never leave the operating room with an unclosed leak. So a successful trabeculectomy is a stable surgical fistula. The one thing required to keep a fistula patent is flow, the principal, and most challenging complication is scarring, and prevention is always vastly preferable to cure. So a little bit on the prevention and management of the complications. So intraoperative, as I told you, you can have buttonhole of the conjunctival flap. So gentle handling is required with non-tooth forceps and suturing with tenonylin in a figure of 8 if it does happen. So episcleral hemorrhage, gentle and sustained pressure, light cautery, use of viscoelastic, choroidal effusion, slow release of the AC is very important. And there, of course, using mannitol preoperatively is very important. Preoperative mannitol, counseling, suprachoroidal multiple incisions to drain the fluid. Vitreous loss during iridectomy due to rupture of the lens annules and the anterior hyaloid membrane. So post-operative complications, you can have hypotony, which is the commonest complication, and flat anterior chamber. Conjunctival defects can be noted with Cyril sign. You can put a pressure bandage or suture that up, or you can also use a bandage contact lens or a scleral shell tamponade. Excessive filtration, again, large bleb and shallow AC. Tamponading the bleb is important. AC formation with either a high molecular weight viscoelastic or a gas bubble. And serous choroidal detachment, use of oral and topical steroids, cycloplegics, drainage of fluid, and AC formation with viscoelastics to raise intraocular pressure. The late complications are leaking bleb, especially in MMC augmented treb, failing bleb with raised intraocular pressure. You can massage the bleb, argon laser suture lysis, start anti-glaucoma medications, needling of the bleb using 5-FU or mitomycin. Encapsulated blebs, digital massage, and you can start anti-glaucoma medications and needling. Cataract formation is one of the complications of trabeculectomy, and of course blebitis, where you can have endophthalmitis also, leak and pain. So that's it. And with that, I thank you for your attention. And that's the team actually who puts up with all my acrobatics in the theater. Thank you very much.
Thank you very much, Dr. Chandrima. That was so good, and it took us through all the very essential steps, and I'm sure the postgraduates would have learned a lot. Why all of us did learn too. Just one question before we conclude. Murli, would you want to take that question? 1 or 2 questions. Maybe we are at the end of it. It's okay. Murli?
Yes, madam. Yes, madam. So, madam, how do you titrate the tightness of the releasable suture?
The releasable suture actually post-operatively generally we, you mean that while doing its surgery?
Like how tight should the releasable suture be? And,
I think it should not actually pull on the cornea. It should be just right that it creates no pull on the cornea basically at the operation table.
No, the releasable suture, the main purpose is to prevent the complication. So in the initial post-operative period, especially during surgery, it should be tight enough. That's why you have to put 4 loops. 3 loops, so it will give way. So 4 loops, so you have to both rows. It should be tight. So that it won't allow any acute to flow out.
Madam, is there any standard, sir, RK sir, is there any standard size of the ostium that you should be?
Ostium, no, it's what Chandrima has shown is good, but usually what I do is I do triangular flap, and my ostium flap is 4x4 always, and ostium is 2 millimeter, 2 by 2. So I will take a little larger ostium, including the little bit of cornea and the sclera and trabecular meshwork, all these things as part of this, up to where the gray zone meets the white zone. Till then I used to take. Not the number of bite, what we are reviewing is more important.
How do you decide on the mitomycin dosage and duration, Dr. Ramakrishnan?
Mitomycin, I normally use almost all the cases of trabeculectomy, but that too also is not rule of thumb. You know, it's depending upon the various factors, suppose primary surgeries versus repeat filter, and also age of the patient. And another important thing is the type of glaucoma, whether it's a primary glaucoma, a secondary glaucomas, and our third, fourth one is the how long the patient is on anti-glaucoma medication. Suppose the patient is on anti-glaucoma medication, especially prostaglandins and all these things, you know, then your concentration should be little more, especially 0.4 milligram per ml for about 3 to 4 minutes. So all it depends upon the various factors. Then only we can decide about the dosing of the mitomycin. If it is a primary filter and a virgin conjunctiva not exposed to any anti-glaucoma medication, 0.2 milligram per ml for about 2 minutes is more than sufficient.
Sir, how soon would you remove the releasable suture? Like if on day one the bleb is flat and the chamber is quite deep, I mean, how soon can you remove the releasable suture?
Yeah. At least you have to wait for a week. Suppose if you remove it immediately, you know, then your chances of going for cellular chamber, and sometimes we had one expulsive hemorrhage, supracortical hemorrhage, sudden decompression, no, you can, chances are more. So we have to be very careful and always put additional scleral flap suture on either side. Suppose if you are doing a triangular scleral flap, some people they do two releasable on side and one at the fixed at the apex, depends on the surgeon's choice. But never do remove the suture in the first post-operative. First, wait for a week.
And what is the concept of teaching Moorfield safe surgery system to resident trainees?
Yeah, of course, that's very, very important because previously our filters are mostly limbal based. So in that case, no, we will be having a localized blab, and another thing what they have to understand is the ring of steel phenomena, because there's a formation of a strong fibrovascular band which obstructs the flow of aqueous from the anterior limbal to the posterior of the space. So there comes your Moorfields because we were doing, so after that only the phonics base become more common. It's not phonics base, but how long you are extending posteriorly. You have to do undermining of the conjunctiva on either side of the rectus and put the medicine much more posteriorly, either 2 or 3 sponges which are touching the pre-margin of the conjunctiva. So in that case, no, you won't, most certainly you won't see the height of the bleb. The bleb will be very diffuse and you will have a very good control of the intraocular pressure. Yes, Moorfield's technique is very much useful, especially this undermining of the conjunctiva and also the keeping the mitomycin sponge in the posterior aspect of the scleral pocket.
It gives a larger surface area basically for their
Yeah, that's correct. Yeah.
Any other questions before we conclude? Murli?
Yes, madam. I mean, sir, what is your experience with the other antimetabolites like Avastin and?
Avastin we have tried in a few number of cases, but the results are not that great when compared to mitomycin. And of course, 5FU also we have tried either sponge, even the injection post-operatively, intraoperatively and post-operatively. But it's not as cumbersome for the patient. You know, it's injection is painful and also corneal complications are more with the 5FU. And that too, the results are not that great. But one thing is vitamins is good, but we should know how to use it, how long you should use it, what concentration, and what are the complications you can expect. All these things you have to keep in mind. Then only we have to go in with the vitamins. Yes. Vitamins is the best.
What is the current role of NPDS, non-penetrating glaucoma?
Of course, now we have, especially I do in cases with advanced glaucoma, where you have a fear of macular washout, suppose a fine curve, 0.9 curve with the macular split phenomena. In that case, I used to do non-penetrating. Usually, the deep sclerectomy with visco canalostomy on either side. That's a commonly done non-penetrating filtering surgery. Yes, yeah. Only not in all cases. In myopes, where suppose a high myopes where the sclera is very thin, you will not be able to use antimetabolite because of fear of scleral thinning and hypotony, other related complications. In that case also, deep sclerectomy will be used.
The AIMS group had come up, I have a question for Dr. Anil. The AIMS group had come up with a 360-degree trabeculotomy with a light pipe.
Yeah, but we have, I don't have any experience except I have tried some with the Prolin suture because we don't have that fiber optic probe and all these things. So with 6-Prolin, we have tried in adult juvenile open glaucoma. In some we were able to, but we're not as a routine. Not as a routine. Yeah.
Thank you very much. I think we need to conclude. Glaucoma is such a vast subject. There's so much to hear and talk. I do hope we keep coming back with more webinars on glaucoma, which would be of great benefit to the audience. Needless to say, it has been one amazing webinar with a difference. And my very deep felt thanks to the most eminent panel and our most respected speakers. My thanks are due to, of course, Mr. Kripal and the admin team of AIOS, Sai and Manjula from Numerotech, Mr. Sunil, our webinar admin. My thanks to my dear ARC team, a source of huge energy and positivity. Our thanks to Sun Pharma and Mr. Nagmohan, who desired to set off a series of greatly valued webinars for the postgraduates, which would happen over the next few months. And finally, and most importantly, my thanks to my dear attendees. And I do wish and hope that we were truly of value today. Thank you, one and all. Thank you very much.